first, just because of what you do right now as your profession, I wanted to start out by asking you what it is you actually do.
So that's always a difficult question to answer. So think of coming from a family where no one is in medicine, no one has been in healthcare. They already have a hard enough time knowing what a doctor does on a day-to-day basis. So trying to speak to my mom, to cousins, to siblings, and tell them what it is I do on a daily basis, they have no concept. And the same thing for my medical colleagues that have decided to stick with clinical medicine and are still doing the white coat bedside direct patient care. I work in health policy. I work in regulatory affairs. I work as an interface that acts on public health and medical priorities that are tasked to me from my immediate boss, who is the Assistant Secretary for Health, but also largely the HHS Secretary, Javier Becerra, and the White House. Let me give you some type of rhythm for a regular day. I might take on a number of podcasts. I might do a couple of interviews that provide commentary on an area of interest, whether that's artificial intelligence and applications in vulnerable populations, or it could be cannabis. It could be regulatory law and FDA oversight on certain elements, differences between marijuana, the flower, versus CBD versus synthetic cannabinoids, Delta 8, Delta 9, questions like that. And I could be somewhere off on another tangent doing maternal child health. I can be doing climate change and environmental justice. There are implications where I get tied into much of the telehealth policy considerations around what stays and what goes, and how do we make the right reimbursement and payment approaches to understand the trade-offs between doing well based on the standard approach to clinical evidence data collection, or where can we start to impart real world evidence that's more representative of the entire population as opposed to a small capture that's typically more well off and white in nature, or kind of the white adjacent, cultures we might think of. My family has a long history in the Navy and the Marine Corps. A lot of the men on my side were the first Black Marines to go into the Marine Corps and be integrated. And there's a strong contingent of folks that have my name that are in Pennsylvania that are all retired Marines, and they were all very well regarded. So I had kind of a high bar to follow. And the only way I was going to serve with the Marines as a clinician was by joining the Navy. So that's why I joined the Navy, because I knew exactly where I wanted to go with the Marine Corps. So the loan repayment was helpful, but I came to the program late in medical school. So they only paid for 1 year of medical school. My primary goal was just to go with the Marines and go into combat operations, which I successfully did, to the good or to the worse, for my ability to provide self-care. And then for those around me, I did succeed in that dimension of it. The benefits in hindsight have been a lot more than I really could have accounted for going into the military. And the way I can relay that briefly is, when we were going through fourth year med school, when we went through internship, we were responsible for one of one. We didn't really have any leadership at that point. We were struggling to maintain our patient panel, right? Going from CCU to the ICU to the med wards to ER to whatever outpatient clinic we get a little breather on. And I immediately went from that and having a state license in hand to the next day being responsible for the training, education, and credentialing of 60 corpsmen, medics, a PA, and an independent duty corpsman, which is a step-down version of a PA in the Navy. Not only that, I was responsible for the health readiness for combat operations and in garrison, meaning in peacetime kind of operations at home, for all of those Marines and sailors. So every buck stopped with me. It's as if I became the CEO for the health system overnight. I was the medical director for this entire population overnight. I became the CMO overnight after having not done that ever in medicine. So it was a very quick change and a very quick expectation of leadership, which drives people two directions, right? So it will either drive you towards humility and finding the answers from the people that have knowledge, or it will drive you to put a mask on and just fake it and fake it and fake it and probably become a nervous wreck and eventually have bad outcomes, right? Thankfully, I chose the former. and relied on a lot of my junior enlisted corpsmen and senior enlisted medical officials, medical department staff to bring me up in how to lead well and to do it in a way that was out of service and not out of a need to declare myself as the expert at all times.